Morning everyone. 10 o'clock, Monday morning again. Happy Valentine's Day. Can't believe you choosing to spend Valentine's morning with me. We should have done a session on the heart today, shouldn't we? That would have been ideal. But yeah, so morning. Now I got a few in. Good. Me and Decat as well, ready? Good. Good morning, everybody. So again, sometimes your name doesn't come up, so apologies. But if you click on the link, on the eCam link, then we'll be able to get you up. Sometimes it depends on your computer settings; it will just reset those things. I need you to have a look, Simon, into a line of clothing which has got the Anatomundi slogan on. I think you and I can make a fortune. Right. Facebook user, good morning. Morning, everyone. And Stevie, welcome. I have no idea how to pronounce that, so I won't even try. Yeah. Good morning. Right then, so we're going to move on from the hip rotators that we did last week and moving into the different compartments around the thigh. Do you know what? I wondered whether somebody might come in from yesterday. So Steph, good morning. I have a feeling that Penny might be here as well. Might be one of the Facebook users. But yeah, we had a long day yesterday. So on the movement therapy diploma that we teach, we do it's basically a 12-week course on the spine. And we had the face-to-face day yesterday of that. So yeah, it was a pretty full-on day yesterday, and Steph was there. And I'm surprised you're here this morning. So good morning. And Nicola, welcome. Good morning. Good to see you back again. Made a few recently, so that's good. Cool, yeah. So looked at the rotators around the hip joint. All of those small little hip rotators, and we were talking about the piriformis muscle and the old kind of piriformis syndrome diagnosis that some people used to get, and now that is better termed, I think. And this is the thing, we have arguments more about what things are called than anything else. The treatment is usually pretty much the same. It's just the diagnosis and the label that you give something is changing. So piriformis syndrome, now we don't really use that term because of all of the muscles that attach in and around that area. So we call it a deep gluteal syndrome, which is more accurate because it's more vague. Okay, and that's the thing. Sometimes with vagueness, we get more accuracy. Because we can't say it's a specific muscle, and anybody that says they can and can palpate those things through the tissue, through the skin, through the fat, through the glutes, and you'll see that in a second, and then onto those specific muscles. Yeah, it's very, very difficult to say you're on a specific muscle. So yeah, I bet you did, Steph. I bet you did. Yeah, a bit of a long drive home. Penny is there. Good. Happy Valentine's to you. Good morning, Sarah. Yeah, specifically vague. Yeah, and I think anything, well, most things, especially with what we deal with, if they're kind of really that sometimes they can be specific. I'll see if I can think of some examples as we go through. But yeah, quite often things are quite vague, and it can be very frustrating. It can be frustrating for practitioners and for clients as well, because we don't fully understand the nuances of pain and dysfunction, whatever dysfunction is. And yeah, you may have seen that I've been having a little bit of a tete-a-tete with someone online recently, and it zaps so much of my energy. but I feel like I have to respond. I just can't not. So I think what I'm going to have to do is just write a whole blog about a lot of the frequently asked questions that I get, and then just go, do you know what? Just have a read of that, and if you agree with it, great, and if you don't, then fine. You carry on doing what you're doing. But yeah, it is energy consuming. So let's get going. I'll just do a bit of a recap from last week. If that's okay, just move me up there. Just move my screens around a second. There we go. Okay, so this is where we started last week. So we talked about that there are different layers to the hip and the gluteal region in particular. So we're looking at the posterior part of the hip, so the back of the hip, and we had 6 deep posterior muscles, and those are the ones that we focused on last week, and 3 gluteal muscles, which we're going to have a look at this week, and something called the tensor fasciolata, or TFL, Transport for London. As you said, Tristan, I always think of that whenever someone says TFL. I have to stop myself. Yeah. Ah, cool. Julie's here as well. So Julie was on the course with us yesterday as well. Oh, wow. Wow, that is a long journey back. I'm sorry you had such a long journey after such a long day. That is dedication. That is well done. So yeah, we're going to start adding these layers on now. So then that will finish off the posterior aspect of the hip. And then we'll start to move into the more superficial muscles. So around, have a look at the hamstrings and the muscles on the front of the thigh, but in relation to the hip rather than the knee. So obviously we've done the knee, we've had a look at where things attach there and the flow of things, but we're going to have a look at now the hip and around the pelvis. So so that's the intention. So just a quick recap of these. So the rotator cuff, this is what I call it. It's the rotator cuff of the hip. It's very similar to the rotator cuff or, around the glenohumeral joint. So the things that help to rotate and maintain the position of the shoulder in its socket. We've got obviously the structure is very different in the hip, so you don't need the stability from the muscles because you get the stability from the joint surfaces and the connective tissue. Yeah, so the ligaments around the hip are really strong. We saw that a few weeks ago, and the acetabulum, so the socket of the ball and socket is deeper, and then it's also got that labrum as well, which provides like a negative pressure to keep that femoral head in position. So there's a lot of similarities, but obviously a lot of differences as well with the hip. So we looked at the gemelli muscles, and there's an inferior and a superior. So they're coming from around that ischial spine area and then onto the back of the greater trochanter. So the greater trochanter, just to refresh your memory, is this bit here. So this is the intertrochanteric crest, because that bit there is the lesser trochanter and that one there is the greater. And this is a raised area, which is a crest. So that is the intertrochanteric crest. And this is where a lot of the deep posterior muscles will attach onto. Okay, so these are very, very deep within the hip. So we had a superior and then we had an inferior, and they were called gemelli because it means Gemini, which means twins, and they both do a very similar job and they both come from a very similar place. Okay, so that's why they were called that. Then we had a look at the obturator muscles. So they attached onto the obturator foramen. If I can get the orientation right there, that bit there. Okay, and it's not a hole in real life. Yeah, there is a gap in it at the top where some blood vessels and nerves come through, but it's actually covered in a membrane, a very thick connective tissue, or very strong connective tissue, I should say, rather than thick. It's not really thick. It's fairly thin, but it's very, very tough. Okay, so the muscles will attach onto the front of it, so that these ones that attach on the front, that's the externus, and the ones that attach on the inside in here, that's the internus. Okay, so we've got obturator externus, obturator internus, and they're called that after their position. So this is the internus, so on the inside of the pelvis, and then the tendon wraps through the lesser sciatic notch onto, so this is the lesser sciatic notch just here, and then onto that intertrochanteric crest. Okay, so again, similar attachment points to the gemelli muscles that we've just seen. And then you've got externus. So this is on the external part, so the kind of forward-facing part, if you like, of the obturator region. And then that also attaches onto that intertrochanteric crest region. And there's a specific bit, so a trochanteric fossa. Basically, it means that there's a little bit of a dip in the trochanter where that muscle usually attaches. Okay, but again, need to kind of get away from thinking about muscles attaching on a specific point, because they kind of merge and spread. Okay, so it doesn't look like the picture here as we saw last week. There's lots of muscles all attaching in that region, and they and the way that they attach to the bone is via the periosteum, which wraps around the bone. So the bones are covered in connective tissue, and the tendons weave into that connective tissue, and then they spread. Okay, so they're very, very tough attachments when the tendon goes into that periosteum, but it's not like a pinpoint; it's like a spread, and which makes sense, because if it was very pinpointed, then any muscles that create any amount of force would be more likely to get injured if they had a smaller footprint, because the attachment site would be too small to withstand those forces, so that it has to spread to be able to dissipate force. And then piriformis, the good old friendly piriformis that most people have heard of. And this one coming through the greater sciatic notch. So we'll have, when we look at the sciatic nerve, you see the relationship between these two things. And we're going to talk about that a little bit today as well, if we get time. So yeah, piriformis starts on the anterior part of the sacrum and then attaches just on the top of your greater trochanter on that intertrochanteric crest again. Okay, so we've got another muscle in there. And then quadratus femoris, which was the last one. So quadratus basically means like quadrangle, like a square shaped, which you can see this is square shaped, and femoris obviously attaching to the femur. So it's on your ischial tuberosity area just here, and then it will go onto that intertrochanteric line, okay, or intertrochanteric crest. So yeah, those were the 6 rotators that we were looking at last week. So they're the deep muscles. We're now going to zoom out a little bit and then have a look at the gluteal region. So let's have a look at this posterior thigh. So hopefully most people have heard of this one. Most people have, even if you've never studied anatomy before. So we've got the gluteus maximus. So obviously maximus means big. So we've got a maximus, a medius, and a minimus. So a big, a middle, and a small one. Okay, so that's what the names mean. And you can see here there's a very, very big muscle with a very short tendon. Okay, so these are really, really powerful muscles, powerful hip extensors, and they also bring about some external rotation as well as a bit of abduction. Okay, but what we tend to forget with these muscles, very similar to the rotator cuff of the hip, is that they help provide stability in the frontal plane. So that's when you're with your body moving side to side. So when you take a step, if these muscles weren't engaged, then as you lift one leg, you just fall to the side. So like a Trendelenburg gait, you might have heard of that. But these muscles activate on that side of the hip to maintain the pelvis position so that you can propel yourself forward. So they have a role in stability in that frontal plane as well. So we often learn muscles in what we call open chain activities. So basically where the leg is free to move, like if you go into abduction, so just bringing the leg up to the side, that will be glutes. If you lift the leg off the floor and then go into extension, so bringing your heel behind you, that's glutes as well. But when your foot is on the floor, that's called a closed chain activity, and then it will work on stabilizing the joints above it. Okay, so we have 2 kind of functions, open chain and closed chain. Most of the descriptions of movements of muscle are described as open chain movements. Okay, but so yeah, but sometimes that's a bit confusing when you first start to learn those things. So we're going to have a look at this muscle. So all around here, you can see this is the iliac crest, and then you've got the sacrum just here, and the glute max will attach all along that iliac crest line. And if someone has got a gluteal tendinopathy, then this might be an area that you would want to look into, okay, because usually that's a bit tender there. And also this bit around here. So just down there is your gluteal tuberosity, which is one of the top parts of your femur. And that can usually be really, really sensitive with someone who has a gluteal tendinopathy. Okay, so they often kind of feel it around this area here. So that might be a little bit more sort of glute medius, but although that's a bit low, maybe glute minimus there. But usually they don't know it hurts here. Okay, so it's worth checking that if you're dealing with people you think might be a gluteal tendinopathy problem. This is glute medius, so this is under glute max, and we'll have a look at the relationship in a sec. So this attaches just under the brim of the iliac crest. And when I did acupuncture years ago, they used to really advocate putting needles all around this area. And again, it's because of the tendinous attachment of the glute med. Okay, so it's an area that can get irritated with gluteal tendinopathies, as well as here. Okay, so the insertion point as well. So we have to think about both ends of the muscle when you're thinking about conditions like that. And then here, glute minimus. So this is deep to the medius, and there is a line all the way along the iliac crest. Let's see if I can see it on this one. I don't think it's very clear in a little bit on this model. You might be able to make it out, but there is a very, very faint line along the edge of this ilium, and there, like I say, this is a real ilium, so you should expect, yeah, there's a little bit there, so you can see a little bit of a raised area there, and that's the line that the glute medius attaches into. Okay, so if you have a look on here, so you've got the ilium between the anterior and inferior gluteal lines. So these lines on the ilium are attachment points for the glutes. Okay, so yeah, that's your glute minimus, so the deepest of all three. Right, let's have a look at those then. So we'll go glute max first of all. I've got about 1 billion videos on here, so let's just make sure we get the right ones. Need to just get rid of all those. Got rid of that one, got rid of that one. There we go. Okay, cool. We're there. So this is the glute max, hopefully. Yeah, looks like it. Cool. Right, let me just get rid of that ticker. Right. So quick orientation then. So this is the right side of the pelvis. There's your iliac crest and your ischial tuberosity just here, and then these are your hamstring muscles just here. Okay. So, and this is a good video actually, the beginning of it, because it shows you the relationship between the glute max and the hamstrings and the ischial tuberosity, which is some of the stuff that we've been talking about recently. That muscle there, don't get confused, that is the glute medius muscle. So we're going to look at that in a bit more detail in a second, but you'll see in a sec that the glute max is over the top, and there it is there. Okay, I'm just going to rewind that a second, just so I can pause it on there. Okay, so that area there, that is all iliac crest, all at the top there. Your gluteal tuberosity is just down here. Okay, so that's the bit that I was saying about you. This is usually really sore with people who have got gluteal tendinopathies. And quite often as well, if you poke and prod around this area, then it will refer pain down the leg. And people think they've got problems with their back because it's going down the leg, but actually it may be a referred pain from this gluteal tuberosity area because of the glute max potentially. Okay, so it's just something to think about. So that's your iliac crest just there. And just press play again. And you can you'll be able to see in a second. So the posterior ilium. So there's your attachment point. So it's a very broad attachment all the way along that iliac crest line, and then also onto the sacrotuberous ligament, which is the ligament that we saw in the first couple of videos. Okay, so all the way along there, so a really broad attachment point. And again, those are usually very tender areas with people that have got gluteal tendinopathy issues. And then the other end of it attaches there. So there's your greater trochanter. So it's underneath there. And then your gluteal tuberosity, which is just there. And there it is there. Okay, so if I just pause that there. So it's this bit here. That there is usually really, really sore. Okay, so there's your greater trochanter, there's your lesser, and you just drop off that greater trochanter onto the femur, and that is often an area where people really struggle with gluteal tendinopathies. Okay, so just something to think about when you're doing your palpation and feeling for areas that are tender. And then you've got glute medius, so just deep to that. Just move me over there. So orientation again. So there's your iliac crest. Okay, this one here this time, don't get confused. This is glute minimus. Okay, so we're going to add glute medius over the top. And then there's your greater trochanter. And then these are all your hip rotator muscles that we've been looking at last week. Okay, so you can see the amount of muscles that attach onto that greater trochanter. Huge, loads of them. Okay, that's why we can't be specific. So there's your glute medius. So iliac crest at the top. So if you think about where the glute maximus went, and you can then kind of ascertain which muscle may be contributing towards the symptoms, especially with the tendinopathy. So the glute maximus attaches all around here, and the glute medius all around here. So it's kind of divided the pelvis into half. So the front half is more glute medius, and then there's a little bit which is TFL at the front. We'll talk about that in a sec. But the back half and all the way down towards the sacrum area and into that sacrotuberous ligament, that's all glute max. Okay, so you can use that to help you figure out which muscle is causing the issues. So there's your glute medius. And these are the attachment points again. So if you have a look here, so this is a very broad one, just underneath the iliac crest, and then the glute max was over the top of that, but it didn't really attach to this area here. It was more from there and then all the way down and then onto that sacrotuberous ligament around here. Okay, so glute max is more posterior, glute medius is more anterior. Okay, so that may give you some clues with some of your people that you see. And then there's the greater trochanter just there. But again, remember, you've got 6, 7, 8 muscles already that we've seen that attach into that area, okay, all around that greater trochanter. And then the last one is this one. So now this is taken down to the bone. So that's the iliac crest just there. So obviously the outside of it. There's your greater trochanter. So iliac crest just there. Sacrotuberous ligament, and that looks like a ligament from a hamstring, the tendon from a hamstring, sorry. Okay, so ligament there, hamstring tendon just there. So you've got a bit of an orientation. There's your piriformis, and then there's your glute min. Okay, so slightly inferior. So glute medius was up here, and there's glute min, the attachment just there, and then onto greater trochanter again. Okay, so you can see now the depth of those muscles and how it's difficult to, especially if they've got a problem on the greater trochanter, it's difficult to say which one's which because there's just so much attaching all into that region. Cool. I'm just checking I've got no questions. Stunned silence so far. All right then, so that's your glute min. And then to finish off that region, we've got your TFL. So we've got tensor fascia lata, okay, or tensor fascia latae, however you want to pronounce it. The TFL, the tensor fascia lata, is the tensor, so it tenses the white fascia. So the white fascia is the fascia that wraps all the way around the leg, and then there's a specific bit that the TFL attaches onto down the lateral aspect, we'll see it in a second, that forms it's like a deltoid. So like the deltoid in the shoulder, it's like that in the hip. So the glute max and the TFL form like an anterior and posterior deltoid on the hip. Okay, so it's a similar kind of structure. So let's have a look at that. See if I can find it. Yeah, there it is. Okay, so I was pointing into space. Fascia lata will be there in a second. Here we go. So there it is there. Okay, so we've seen this before when we looked at the knee, and now obviously we're focusing on it around the hip. So that's the fascia lata. It wraps around your whole leg, and it's continuous all the way down the foot, all the way up your body. You're literally just surrounded by this stuff. So let's have a look here. I'm just going to pause that again. So yeah, wraps around the whole leg. That bit, I don't know whether you can see that. There we go. This is your iliotibial band, iliotibial tract, whatever you want to call it. That little pocket muscle up there, that's your tensor fascia lata. And you can see the pull of that muscle and from the glutes along that line. Okay. And that is why the IT band is thicker around that region, because of the pull of the TFL, the pull of the glutes in making you walk or run or whatever it is you're doing. It pulls on that tissue, and then the tissue adapts by laying down more fascia. Okay, so that's why we have a thicker portion on that IT band. But it's not just floating there on its own. It wraps around the whole leg, and it's also underneath here, which we'll see in a second. It is firmly attached to your femur, so it can't slide anywhere. It can't glide anywhere. It's like a cylinder, and then that cylinder then has attachments coming into the bone. Yeah, so it's fixed in place. You can't move it. It's absolutely solid. So let's have a look at that. So just missed my little tribute then. Okay, so ITB thickened, and then your TFL. There you go. Just for you, Tristan. So TFL just there. So that's your tensor fascia lata, and you can see the direction of the fibers have been pulled in that direction to create that thickening. And up here, it attaches onto the iliac crest. Okay, so that's so if you think about what goes there, so we've got TFL right at the front, then you've got glute medius, and then you've got glute max around the back. Okay, so running over the iliac crest, that's the kind of order in which things go. So we'll strip these away a second. So anterior lip of iliac crest, and then down here is Gerdy's tubercle. So that's the bit that it attaches into, and we talked about that during the knee. So this is what we see in the books. So we see this thickening and everything else taken off, but that's not how it works in real life. And then this underneath here, just pause that there, that is your lateral intermuscular septum. So what it does is it attaches firmly onto the femur, firmly onto the underside of the IT band, and it creates a division between your anterior muscles, so your vastus muscles, and your posterior muscles, so the hamstring group. Okay, so there is a compartment that is divided by this really, really thick piece of fascia. Okay, so dividing the front to the back. And you've got another one on the other side as well. And we looked at that a couple of weeks ago. So that big thick tendon there, that's your tendon of biceps femoris, and that's where your IT band will attach on Gerdy's tubercle just there. Okay, so, and there's your glute max again. So it shows the relationship between the glute max attaching into that IT band with the TFL. So you've got the that deltoid kind of formation around the outside of your hip. So there's the TFL attachment, tensor fascia lata attachment just there, and then into the IT band. Okay, just seeing a message. Let's have a look. So Stevie, could your TFL be different depending on the sport you take part in? Yep, absolutely. Yeah. So it will develop. It develops massively in sprinters. So if you have a look at some of the elite sprinters, 100-meter runners, they have huge TFLs. Absolutely massive. Yeah. So yeah, if you're involved in sport that involves a lot of high loads going through the hip and a lot of hip flexion, then yeah, you're more likely to have an overdeveloped TFL because your body will adapt to the movements. Yeah, definitely. Good. Okay, so that's your TFL. First round done. Right, and there's a little picture of it that we saw earlier. Okay, so we're going to have a look at the medial thigh now. So on the inside of the thigh, and this is a way to remember your adductor muscles. So if you have an exam and you're thinking, oh God, how am I going to remember those? There's loads of muscles to remember. Then you can think of 3 ducks pecking grass. Okay, and you need to say this in a more northerly accent, Midlands and North. Otherwise, it doesn't work. 3 ducks pecking grass doesn't work. Okay, so 3 ducks. I've got to be careful how I say that. 3 ducks pecking grass. That's what we've got to do, or grass. So 3 ducks are your adductor magnus, longus, brevis. So adductor magnus, longus, brevis. Those are your 3 ducks. Pecking, pectineus, grass, gracilis. Okay, so 3 ducks pecking grass. There is another way of remembering it as well that Bonnie Southgate said, and it stuck with me, and it's good as well because it says the order in which those muscles go in from medial to lateral. So it's please baby love my groin. There you go. Is it medial lateral? No, lateral to medial. Sorry. Yeah. So pectineus is the most inner, and then so that's please, and then baby is brevis. Please baby. Love is longus. My is magnus, and then G is gracilis. Okay. So please baby love my groin, and that's the order of the adductor muscles. Okay. So if you're doing exams, those are nice little ways that you can remember things, and if they're rude, you usually remember them even better. Okay, so 3 ducks pecking grass, and we're looking at the obturator region. Okay, so these muscles are all in that medial compartment. So there is a compartment that is separated by septum for this medial part of the leg. Okay, and that medial part of the leg is supplied by the obturator nerve. All right, so we're going to, and obturator basically means to close. So if you think about what those muscles do, they adduct the leg, adductors, so they will close the legs. Okay, so that's what obturator means. And here we go. So we've had a look at some of these before, but we've mainly focused on the knee portion. So for example, the adductor magnus, we were really interested in this bit here during the knee, because that's how you get blood from the front of your leg to the back of your leg. Okay, so there is a hiatus, adductor hiatus just here, and that's where your blood supply goes to the back of the knee. Okay, we're going to be focusing a little bit more up here. So that's your magnus, which obviously means very big. Then we've got brevis. Brevis means short. So brevis is what your shortest adductor muscle, and that's we'll have a look at that in a sec. Then we've got longus, which is long. We've got an adductor brevis, short one, longus, long one, magnus, massive. Okay, so magnus is like a hamstring. Okay, so if you think about the attachment point of magnus, and we did talk about this on the knee, just go back a couple. So just there, because of where the attachment point is, we get some extension in the hip from adductor magnus. Okay, so it's thought of as one of contributing towards hip extension, like the hamstrings. Okay, so yeah, and it's very, very powerful muscle and often overlooked for injuries. I think it's again kind of groin issues, but it might be adductor magnus. So you've got brevis, short, longus, long, and then we've got pectineus, really, really small one. This is usually injured in footballers. Okay, so and it's right up in the groin. So you can see there on that superior ramus. So this is the pubic area, and that's the branch of the pubis, the superior branch. So superior ramus, and then that comes down. It's like literally right in your groin. Okay, so when people say that they've got a hip issue, they usually point to the side of their thigh. okay, because they think their hip is there, but the hip is in the groin, okay, so the hip is here. And usually if it's there and they're going, yeah, it's in my groin, then it's possibly this area here. If they're saying it's in my hip, then it's probably the gluteal region rather than the hip joint. So quite often patients get a bit worried because they think, oh, I've got a problem with my hip, and it's basically greater trochanteric. Yeah, so it's not the hip joint, it's outside of that. So just basic anatomy will really help them just ease their mind and their worries. So pectineus, the small one, and then we've got a long one there, which is gracilis. Now the gracilis crosses the knee and attaches down here on the pes anserine, and we looked at that. We've looked at that before when we've looked at the hamstrings attachments around the knee. Okay, so let's have a look at some of those, and if you've got any questions, just pop them in the comments. Okay, just get rid of that one and that one. Here we go, medial thigh. Okay, so we've got a couple together here. So we've got Magnus. Yeah, here we go. Hopefully. There we go. Okay, so yeah, some of the ones that we've seen, like I say, we've seen these before. So this is your adductor magnus. So what it looks like in the books, and then with the adductor hiatus just there. And then let's have a look for real. That's what it looks like for real. So there's the hole. Okay, so that hiatus that the blood supply will go through. Just through to the back there. And then this is the attachment up at the top. Oh, just missed it. There we go. Just pause that right at the top. And then you can see the attachment. Oh, just missed it again. Just up on there. Okay, so right on that pubis. So it's near the pubic tubercle is your attachment. But then it also attaches all the way down the femur. So huge muscle. Looks a bit like a wing. Okay, and that kind of forms the floor of the femoral triangle, which we'll have a look at when we get into the blood supply and nerve supply. We have covered it a little bit already. And then we've got longus and brevis. So let's just have a look at these. So again, orientation of everything here. So there's your magnus, there's the hiatus, which we've just looked at, femur and greater trochanter. So let's layer these on. And then there's your brevis. And again, if I just pause that there, so you're looking at an attachment right on the pubic bone. Okay, so it's really high up, and it can be confused there for inguinal hernias. Okay, so sometimes if you've got a sports person issues here, then rather than a hernia, it can be a sportsman's hernia, which is basically an irritation of the either adductor brevis, longus, or pectineus. Okay, so it's one of the short adductor muscles that attach in here that is causing the irritation rather than a hernia. But to know that, you'd need to get it imaged. So there's your longus next to it, and those are your attachment points. So you can see how close they are right to that pubic tubercle. So there's your pubic tubercle just there. This is your inferior ramus. So ramus, remember, is a branch. So that's where it's attaching in there. You have to be pretty confident with your palpation skills to be able to palpate this region here. Okay, and if you've not really been shown how to do it, then I would steer clear of that region. You don't really want to be poking and prodding around if you're not sure what you're doing. So definitely get yourself on a hip and groin masterclass, or something like that, where they go into the detail of how to palpate it. And because it takes there's a few things that you need to make sure that you do so that you don't make the patient feel uncomfortable. It's obvious reasons, really. So there's your brevis attachment, there's your longus attachment, and then those muscles then attach onto just to the side of the linea aspera, which is what we've seen before when we looked at the knee. So there's longus and brevis, and then longus forms the roof of the adductor hiatus. Okay, so that's those there. Cool. And then let me just grab this for you. I just find it because it's not loaded up. There are so many videos because so many muscles for this. I'll just see if I can find this one. Bear with me a second. So the last one we've got is the pectineus and gracilis. So just get onto the right area. There we go. Hip and pelvis. 10-2. And medial thigh. There we go. That's the one. Okay, just open this up. Here we go. Hopefully. Okay, just get rid of that. Here we go. Okay, so there, this is really now really high up on that pubic rami. So there's your pubic ramus. This is the top of your femur just here. There's your adductor magnus. So you got longus on top, and then there is your pectineus. So you can see how many muscles are up in this region. And like I said, this is the one that usually gets injured with footballers. That short adductor. So there it is. There, superior ramus. And then it comes around the back and onto something called the pectineal line, which is just there. And I'm in the way of it. There we go. And then that one there is your gracilis. So now you've got your three ducts pecking grass, gracilis, again, around that same area as the adductor brevis and longus, but down onto the pes anserine area just there. Okay, so those are all of the muscles of your medial thigh, and cool. Just want to do a couple of other bits, and then we're going to have to do another session next week on the muscles anyway, because we're going to bring in some of the pelvic floor. But I just want to go over psoas and iliacus, because it's an area where if you've done manual therapy before, then we've learned about sort of palpation and all that of this area. I just want to show you how difficult that might be. So anterior thigh, rectus femoris we'll have a look at on another time, but we'll have a look at this next week. Psoas and iliacus. So psoas attaches on your vertebral bodies, the discs and the transverse processes L1 to L5. Okay, so all the way down that lumbar spine. And then it comes underneath your inguinal ligament, which will be here, which we saw the other day, and then onto your lesser trochanter. So it wraps underneath and swings around the back of the leg. And it's joined by a muscle that sits here, which is iliacus. Okay, or iliacus sometimes it's called. There we go. So there's iliacus, and that has exactly the same trajectory as that psoas. And then they join together to form the iliopsoas tendon. Okay, but they do there's arguments to say they do two different jobs. Okay, we can kind of debate about that. So this is what they look like. I just want to show you how difficult it would be to be able to palpate some of these areas. Okay, so here is psoas. Just want you to see how deep this muscle is. So there's your vertebral bodies, lumbar spine just there. There's your psoas muscle. Okay, and what's not in this picture is the fact that on top of that psoas muscle are your guts, and then on top of that is your abdominal wall. So you've got layers of transverse abdominis, rectus abdominis, internal and external oblique, then the fat, and then the skin, plus the intestines. Then you get to psoas. So if you think that you are palpating psoas, then you might need to think again, because it is such a deep structure that you might be feeling something, but you wouldn't be able to say for sure that it was definitely that. And my argument has always been with this, because people say, well, you know, working on this area or the doing treatment to the front of the hip helps with something like a Thomas test, and I have no problem with that whatsoever. But I would debate whether you're actually impacting the psoas. I think you have to be quite broad, and you say, by touching the skin on the anterior part of the thigh, I help hip extension. And I think you have to keep it as broad as that, because I don't think you can say by me pushing on psoas it's going to help hip extension, because it's too specific. It's very similar to the deep gluteal and piriformis syndrome thing. Okay. Same again with the iliacus muscle just around here. Okay, because there's so much tissue to get through, and as Sarah said just there, get your comment there. It's amazing to see this in the cadaver workshops, and it is. When you see it, and you have to physically move all the guts out of the cadaver to get to the psoas, and then when you look at it, you're thinking which one's psoas, because there's so much connective tissue around that area. So it's not as simple as things are made out to be. And then the last one we're just going to have a look at is iliacus, and there it is there. So running next to psoas, which is here, and it fills all of that space. That iliac fossa runs underneath the inguinal ligament, which will be here, so attaching the pubis to the ASIS. Underneath, so it follows psoas underneath onto that lesser trochanter. So there's the inguinal ligament, and we'll look at this again in a bit more detail when we look at the femoral triangle. So all under there, and look at the tissue that's there. There's so many muscles around that region, and then lesser trochanter just there. Okay, so we're nearly done with the hip. There's a lot of muscles that you will have heard of and you've probably learnt about because they're main hip flexors, they're the main adductors, they're the main kind of knee extensors as well. So we've got a lot of muscles that you would have heard of no matter what kind of training that you've done or background you come from. Some of the rotator ones, maybe not so much, maybe have heard of them, didn't really know where they went. But hopefully you get an appreciation of the amount of traffic in that area, and the fact that by being vague we're actually being specific, because that's as specific as we can be. So I think quite often we can become a bit disheartened because we think, oh no, what we've been told is a load of rubbish and it doesn't work and all that, and it's not to do with that, it's to do with how it works. So we know that manual therapy can help these things. If you do manual therapy, we know that exercise can help these things. We just need to change what we say, and because we can't be that specific. It's virtually impossible to be that specific with things. So keep doing what you're doing. It's just that the explanation probably needs to be a little bit different, right? And that's it. And that's what you see from the anatomy when you get to know it in a bit more detail. So hopefully that's helped, cleared up a few things around the hip for you. So we've still got a few of the superficial muscles to go, and then we'll go then into the pelvic floor next week. So I'll see you next Monday, 10 o'clock. Cheers, guys.